All right. Once again, welcome. Good morning to some, good afternoon to others. Welcome to September 21st edition of It's Worth a Shot. And this week we will be discussing the COVID-19 bivalent booster recommendations, along with cohorting and patient placement. We're fortunate enough to have two guest speakers with us this week. Michelle Funches, the Adult Immunization Coordinator from the Montana Department of Public Health and Human Services, as well as Erica Baldry, the Infection Control and Prevention Section Supervisor for Epidemiology for Montana Department of Public Health and Human Services. Next slide, please. As always, a few housekeeping items. Feel free to add your webinar topics, clinician ideas into the chat, and we'll continue these every Wednesday. And we have a polling question this week. Polling question, do you have access to COVID-19 bivalent vaccine? Yes, you've already administered. Yes, you have clinics already, but haven't administered. No, waiting to hear about access. Yes, but our residents and staff don't want it. Other, feel free to enter in the chat. Thank you guys for participating in the polling as always. I'll give you a couple more seconds and then we'll go ahead and close it out. All right, Mary. All right, looks like majority answered yes, you've scheduled the clinics, but you have not administered any yet. All right, thank you guys. Share those. All right, next slide, please. As always, many thanks to all our guest speakers and attendees. And as I mentioned, we're so fortunate to have two guest speakers from the state of Montana on today's presentation. Next slide, please. Couple questions that came up within the last 2 days. First one, are monovalent COVID-19 doses not considered booster doses anymore, only bivalent? So does that mean most everyone is not up to date? And again, Michelle will be touching base on this today, but we wanted to make sure to move this forward in our Q&A opportunity. So to clarify, really to clarify, the bivalent boosters became available earlier this month. So at this time, the monovalent, those original boosters, those stopped being offered as new booster doses. So if someone has received an original monovalent booster, and here's the key word, more than 2 months ago, and again, I'm sure Michelle will be sharing this forward, then they have not yet received an updated bivalent booster, then they would be considered not up to date. And this is going to be important as that NHSN surveillance reporting, Q4 reporting, those changes go into effect on the 26th. And if you guys have questions, feel free to drop in the chat. We'll try to get those. Next slide, please. So question, as the NHSN surveillance definition reporting is now changing, will the new up-to-date definition change on the resident pathway reporting as well on that September 26th date? Yes, the answer is yes. So across NHSN, the surveillance definition of up-to-date with the COVID-19 vaccine will be updated September 26th. All right, next slide, please. With that, I'm pleased to pass the baton to our guest speaker from the Adult Immunization Unit with the state of Montana, Michelle Funches. Michelle, the floor is yours. Thank you.
Thank you, everyone. Thank you for having me. So we are going to look at a high-level overview of the new recommendations surrounding the bivalent boosters. Next slide, please. So overall, the two products for the bivalent boosters, the Pfizer and Moderna, were authorized on August 31st, with shipments kind of being initiated shortly after and around Labor Day. The Moderna COVID-19 vaccine is authorized for persons 18 and older, while the Pfizer is authorized for 12 years and older. Next slide, please. Okay, so what I consider like the summary of the recommendations that have now, hit our nation, right? Everyone ages 12 years and older is now recommended to receive one, what they consider age appropriate because of that difference in age availability between the products. One age appropriate bivalent mRNA booster dose after completion of any FDA approved or FDA authorized monovalent primary series or last monovalent booster dose. So essentially that means two different things. One is this is a booster. It is not part of a primary series, and persons who have not completed or initiated a primary series are not eligible for this dose at this time. And as far as monovalent boosters, the consideration is actually universal. So anyone, whether they did the primary series alone or additional doses or supplemental boosters, everyone across the board is now recommended to get one bivalent booster. The monovalent, as we touched on in the Q&A, monovalent mRNA COVID vaccines are no longer authorized for use and as booster doses and cannot be given as booster doses to anyone 12 years and older. Next slide, please. All right, I like this table a little bit better than two of the next ones I'll show you that the CDC put out, because I think this does a really great job of simplifying it or sending home that message of this being basically a universal recommendation for persons 12 and older who've got their primary series. So regardless of how many doses or booster doses have been administered in the past, we're looking for a 2-month interval from last dose. And then everyone is recommended to get that one bivalent. Of note, we see this occasionally, but if eligible, so if they have met that 2-month threshold from the previous either primary dose or booster dose, they should not be denied based on total number of doses. So even if that feels in excess, or if there was administration errors or in excess of what would be expected, the recommendation is still to administer that bivalent dose at least 2 months after the last dose given. Next slide, please. Okay, so what we see on the screen right now is the CDC's recommendation display for persons who are not severely or moderately immunocompromised. So the top table looks at your standard series for Moderna Novavax or the Pfizer series with the primary dose followed by the second primary dose at the appropriate interval. And then looking at least 2 months to getting the bivalent booster. The reference for regardless of previous monovalent booster doses, I feel like to me, maybe that's a little confusing the way it's displayed, but what that again just means is doesn't matter if they've had a booster dose in the past or if they're just closing out that primary series, you are looking for that 2-month. That's really that window. That's very important here. And then of course with the Janssen series, primary dose, obviously a lot of people who got the initial Janssen series were openly recommended to get an mRNA monovalent and did, regardless whether that was considered a booster or a supplemental dose, looking for that 2 months to administer the bivalent dose. Next slide, please. And this next slide looks at just your population that is immunocompromised. So where persons who completed the Moderna or Pfizer primary series were recommended to get that third primary dose to close out their kind of quote unquote primary series. So we didn't consider it a booster, we considered it a third dose. And then those persons would also be recommended to receive the bivalent booster at least 2 months. Same with the Novavax and the Janssen. And next slide, please. So some considerations for persons who have active or acute illness for COVID-19 vaccination. At minimum, the recommendation is to defer vaccination with any COVID-19 vaccination, including the bivalent, until that person has recovered or the criteria to discontinue isolation has been met. And sorry, I have a little something there. People who had recently had a confirmed diagnosis of COVID-19 may elect to delay COVID vaccination, including, again, the bivalent booster by 3 months from the symptom onset or positive test. And next slide, please. So co-administration, the text here is a little bit broad, but there is a consideration that we want to pull into this. So both Pfizer and Moderna vaccine bivalent boosters can be co-administered with any other vaccine at this time without regard to timing or simultaneous administration. The only consideration, it's not against, I guess, the rules, but there is a consideration for persons, particularly adolescent or young adult men who have received the monkeypox vaccination. They may want to consider waiting 4 weeks before receiving a COVID-19 vaccination. And again, including anything from the primary to the booster because of an observed risk of myocarditis or pericarditis. And next slide. Looking at flu season, there's been a lot of messaging around that, but the overall take-home hope message is that providers should be offering influenza and COVID vaccines at the same visit for eligible persons. And of course, just administering in different limbs, with both actively starting to circulate, and the end goal being the prevention of severe disease, hospitalization, and death, of course, really looking at not having any missed opportunities around that visit, where persons are really coming in to get those boosters. And next slide. Okay. And that was pretty much mine. Very, very quick. I put a couple resources in there that we reference most commonly. So the clinical considerations and some product information. And
Thank you.
Thanks, Jessie. So we switch to questions.
Yeah, thanks, Michelle. If anyone has any questions, feel free to drop those in the chat. And I do see that Kyla put in the link for the clinical outreach and communication activity, those informational calls the CDC does. She put the link in the chat for you. You might have to scroll up a little bit, but it's a lot of what Michelle just covered and some great information. So feel free to share that forward. So thank you so much, Michelle. Appreciate it. And Erica, we will go ahead and pass the baton to you, Erica Baldry from Infection Control from the state of Montana. Thanks for being here, Erica.
Thanks, Jessie. All right, next slide, please. All right, so I'm going to talk about cohorting and quarantine and isolation today. It's going to be a refresher for a lot of you, but I think a good reminder as we've been working COVID-19 outbreaks here in Montana. It's definitely a topic of discussion when we do outbreak response. This is the guidance that's most up to date as of today. We may be seeing updated guidance very soon. So please just keep that in mind that this is updated as of today, but things may change soon. So what is cohorting? Cohorting is the assignment of a geographic area to 2 or more patients who are infected with the same pathogen, but do not have evidence of co-infection with another pathogen. So it is disease specific. So for example, 2 individuals that have COVID-19, but we know that they don't have other communicable diseases. If we had somebody that had MRSA and COVID-19, we may want to look at cohorting or putting that individual in their own room and not cohorting with others. So we stop the spread of other communicable diseases. Cohorting refers to designating a unit or an area within a facility or placing 2 or more patients with the same pathogen in the same room. So we're going to talk about this in a little bit more detail in a few slides. And then finally, cohorting is principle-based cohorting contributes to the control of outbreaks. So it's a tool that we've been using in infection control as well as communicable disease well before COVID-19, but it's definitely come to light during the COVID-19 pandemic. Next slide. All right, so if you've ever been on a presentation with me, I love to get the audience involved. So if y'all could get your typing fingers ready and just start typing in answers. Can you think of why we would cohort patients or residents with the same pathogen? Let's think of some reasons why we'd want to do that. And feel free to use chat to do that, please. To reduce infection. Limited single rooms. Totally, Maria. I think we've definitely started to see this with the most recent wave. 1, air, so airborne infection isolation room to save PPE. Great point, Maria. Efficacy of resources, especially staffing. Isolation and less, oh, it's going fast. Contain infection, decrease transmission, avoid cross-contamination. You guys are spot on. So if you can just press enter. So here is the list that I came up with to control the spread of disease, reduce environmental contamination, limit exposure to other residents, limit exposure to other staff, limit the outbreak. You know, the quicker we can control the outbreak, the sooner we can close it. That's always our goal. And conserve personal protective equipment or PPE as needed. So that you guys were all spot on. Next slide, please. All right, so as I had alluded to earlier, going to talk about dedicated care areas and cluster of rooms. So one option we have when we talk about cohorting is clustering by space. So if separation is by individual or cluster of rooms, we could consider visual cues. So that's why I put that little red line on the slide. That's red tape that's distinguishing the COVID unit from the non-COVID unit. Resident doors may need to be kept closed depending on the disease. So this presentation, I wanted to kind of come from a very high point of, really any communicable disease, although I'm going to mention COVID-19 as we go throughout the presentation. So we really need to look at what disease we're dealing with, and cohorting 1 or more positive residents in the same room if other communicable diseases are not a concern. So we already kind of talked about that of, if we have somebody that has a multi-drug resistant organism or a carbapenemase producing organism, we wouldn't want to cohort them with another person with a different communicable disease, or else we're going to see spread, right? So we definitely need to make sure that it's disease specific, and you definitely want to check with your life safety in your state when we're talking about if we're closing doors or how we are going to separate COVID units from non-COVID units. Next slide. All right, we all understand that sometimes you just can't set up a COVID unit. You don't have the space. A lot of our facilities have started to fill up, especially in this last wave. And so we just didn't have dedicated areas where we could be shuffling people around. So, if we have limited space, or if single rooms are very limited, or we have numerous residents who have all had, turning positive at the same date, and it just seems like it doesn't make sense to shift people around, we can isolate in place. And that's what this image is showing, is we have different units and we have different individuals just isolating in place because it doesn't make sense to move them at this point. Next slide. So question for the group, and I'm really interested in what you guys have to say here. So when do you communicate with staff to follow transmission-based precautions? And the first question is when they're entering a COVID unit. So how do you communicate that to your staff? Do you use signage? Do you use tape on the ground? What does that look like? And then if they're entering a COVID positive room, so what kind of signage do you have on doors or the unit itself? I'm just kind of interested on what tools you guys are using within your facility type to really indicate to staff that, hey, you're entering either a positive COVID patient's room or you're entering the COVID unit. So if you just want to put it in chat. Andy says signage identifying, signage Droplet and contact isolation signage, signs, lots of signs and PPE cart. That's great, Maria. Signage, signs on the outside, visual signs, wonderful. I know one thing we've seen when we've been doing our iCars here in Montana is we don't always see that signage. So I'm really happy to hear that you guys do have signage. We never want to assume anything and assume staff know, right? So as many visual cues that we can give, the better for protecting our staff and making sure we're taking those proper precautions. Thanks all. I appreciate you guys participating. Next slide, please. All right, so, we have our ideal situation. If everything was perfect, if we had all the staff we needed, if we had all the room that we needed. So in an ideal situation, we would have a dedicated unit for the infectious disease, whether that be influenza, norovirus, COVID-19. We would talk about this on a disease, specific basis. Dedicated staff that only work the infectious unit. We all know staffing shortages are occurring though, but as much as possible, we try to have dedicated staff. A dedicated bathroom and break room for staff that are working the COVID unit. Dedicated entrance for staff working the COVID unit. And staff use appropriate personal protective equipment, including fit tested, NIOSH approved N95s. Next slide. I just wanted to share with you guys what the CDC guidance says. So this is current as of today. It may change, but what they say is the location of the COVID-19 unit should ideally be physically separated from other rooms or units housing residents with confirmed COVID infection. This could be a dedicated floor, unit, or wing in the facility, or a group of rooms at the end of the unit. So if you've ever worked an outbreak with me, this is usually what I go through is, okay, can we dedicate a floor to it? No. Okay, can we dedicate a unit to it? No. How about a wing? No. Okay, let's group them at the end of the hall, right? So we're going to walk through and see what makes sense for your facility. And then to the extent possible, we really want to restrict access of ancillary personnel to the unit. So once again, dedicated staff, so we're not continuing to spread or expose additional staff. Next slide, please. All right, so cohorting buckets, this is kind of how I think of it. And I know, there's a long-term care facility I've worked with, and this is kind of how they've explained it to me as well is, we have our green, yellow, red, we have regular rooms, quarantine and isolation. Regular rooms are asymptomatic, negative, non-exposed residents. Quarantine are exposed, but they aren't positive and they're not symptomatic. But because they're exposed, we want them to have their own room and own bathroom. So if they do become a case, they don't contribute to spread. And then isolation, which is positive residents. And this is where we can cohort residents with known infectious diseases, the same infectious disease in the same room as needed. Once again, how I remember this is quarantine equals exposed and isolation equals infected. Next slide. All right, so I wanted to go into quarantine and isolation just a little bit more for you. So quarantine, once again, equals exposed. In Montana, vaccination status can be taken into account for long-term care facilities and assisted living facilities and nursing homes. We cannot technically take into or discriminate based on vaccination status for other facility types. PPE worn if the healthcare worker to healthcare worker exposure. So once again, we can say, okay, was the healthcare worker that's positive that exposed another healthcare worker, what PPE was being worn. For isolation equals infected. So with isolation, we do not take into account vaccination status because a case is a case. However, release from isolation can differ depending on if they're a healthcare worker or a resident, depending on what staffing mitigation strategy is being used for healthcare workers. Disease severity, if it's mild illness versus a very severe case. Symptom information, are they getting better? Are they fever-free? Do they meet the release from isolation criteria? And if the person's immunocompromised or not. So releasing from isolation is kind of an equation, and we have to work through when that person can be released from isolation. Next slide. Things to avoid. So I just wanted to put together a few things that, we should think about maybe not doing to the extent possible. So one is not dedicating staff to separate units. Once again, that's going to depend on your staffing, but as much as possible, dedicating staff. Allowing residents in Jack and Jill bathrooms to continue to share their bathrooms if one is on quarantine or isolation and the other individual is not, or if both are on quarantine, right? Because we don't want to expose the other resident. This is really important for infectious diseases such as norovirus. Allowing positive staff to work with negative residents. Once again, we don't want to expose residents. to COVID-19 or to other infectious diseases. Keeping an exposed resident in the same room as a positive case. I understand sometimes this has to happen, but we really, really try everything we can to not have this happen, because we don't want to just assume that somebody's exposed and they're going to become a case. And finally, placing residents with pending testing on an infectious unit. So saying, well, you know, they did have a sniffly nose, their COVID test is pending, we're just going to move them to the COVID unit, right? We want to make sure we have confirmatory testing before we do that. Next slide. Here are just some considerations for cohorting. So how far into quarantine are the residents? You know, are they on day 6 or 7, or are they on day 1 or 2? Is daily symptom monitoring or testing occurring? Do you guys have a good idea of what's going on in your facility? Is the resident immunocompromised and maybe at increased risk of acquiring the disease or spreading it? Was the level of risk of exposure that put that resident in quarantine higher or lower, right? Did they have a really close contact, or was it like, well, we think they may have been, you know, within 6 feet for 15 minutes or more? Can the resident wear a mask and perform hand hygiene, perform toileting and practice physical distancing? You guys know your residents better than I do. What's the air exchange in the space? You know, is it super close, or was it, you know, outside? How often are rooms cleaned or disinfected? And are there multiple organisms of concern? You know, is this, are we having multiple diseases spreading throughout a facility, which we've seen? Next slide. This is just a snapshot from CDC, and just a friendly reminder that source control is still recommended within the healthcare setting, and it goes through, you know, what we should be using as source control. Next slide. And then final thoughts, you know, we understand you have limited space in your facility, so we ask that you do the best that you can. We understand that you may not always be able to have dedicated staff or a dedicated COVID unit, but let's work through that together. Here in Montana, we offer one-on-one consultations with our facilities in outbreak to walk through, okay, what does the outbreak plan look like? What makes sense for your facility regarding cohorting? What can we do to stop the spread of this organism? And the quicker we can talk and the quicker we can get a plan in place, you know, the better we can stop transmission from occurring. And then I really sincerely want to thank all of you for all that you guys continue to do. It's been a really long couple of years for everybody, but I still talk to, you know, DONs and admin and IPs that are in it and continuing to do the right thing and continuing to want to do what's best for their resident staff and community. And I just sincerely want to say thank you for all that you do. Your work is important and valued. And I think that's all I have for you.
Thank you, Erica. We appreciate it. And we definitely thank you. And we thank our guest speakers. We thank you guys for your partnership, helping keep us informed and educated as guidance seems to change and evolve before our very eyes. So we can't thank you guys enough for helping us too. So we appreciate it. Excellent information, both of you. Any questions? Feel free to reach out to us if you think of anything, and we can definitely reach out to Erica and Michelle, and you know, if anything comes up, we can make sure to follow up next week or sooner. Next slide, please. Well, see everyone next week, Wednesday, September 28th. This will conclude this week's edition of It's Worth a Shot. Have a great afternoon, everyone. Take care and be well.